Yes, okay. I am going to turn my video off because I'm having some trouble with my Wi-Fi. So I wanted to make sure my presentation is coming through appropriately. So I will switch to presentation mode. Do you all see it on presentation mode? Yes, okay. So once again, thank you very much to the organizers for giving me this opportunity to present this talk. It's a vast topic, and so I'm going to try my best to summarize as best as I can in the time allotted to me. So my topic for today, I was going to speak about novel therapies for sickle cell disease. And we start off with the sickle cell mutation itself. As most of you are aware, it's sickle cell disease. The hemoglobin S mutation is caused by a point mutation in the 6th codon of exon 1 in the beta globin gene, with the amino acid switch as has been described on the slide. The mutation itself is multicentric in origin. There are four main haplotypes described. There's the Arab Indian, the Senegal, the Benin haplotype, and then the Bantu haplotype. They've been listed in order of severity. And the Arab Indian and the Senegal haplotypes are known to be least severe. And these have been described mostly in relation to the hemoglobin F content in the red cells from these particular individuals. The higher the F level, the less severe the disease phenotype appears to be. So as we talk about the worldwide distribution of the disease, as you can see, there's very high prevalence of the disease in the African continent and various distributions across the world, but it is definitely a disease that we see all across the world. The sickle cell mutations themselves, there are, besides the hemoglobin S, the association with S and C, S and D, and S and O also gives you a sickle phenotype. And there are various different hemoglobins that are produced as we talk about the different mutations. Overall survival was described by Dr. Ora Platt way back in the 90s, showing in this first panel here that individuals with SS do poorer than individuals with normal phenotype. Individuals with hemoglobin SC appear to survive longer than individuals with SS. And your fetal hemoglobin level definitely plays a role in the severity of the disease and ultimately in overall survival as well. The pathophysiology has been linked to the hydrophobic valine that's exposed when sickle hemoglobin assumes the deoxygenated conformation. This leads to abnormal interactions with neighboring beta chains forming the polymers, which tend to be insoluble. And there are three variables that dictate polymerization of hemoglobin S, and these are cellular oxygenation, intracellular hemoglobin S concentration, and the presence and quantity of fetal hemoglobin inside each red cell. The pathophysiology itself, the oxygenated hemoglobin S is, as I described, extremely soluble. The deoxygenated hemoglobin S forms bonds with the adjacent hemoglobin molecules, forming the tetramer, which is insoluble. The polymers form very rapidly within milliseconds, causing distortion of shape. The cells get less deformable. There is injury to the vascular endothelium, resulting in microvascular occlusion, ischemia, and upregulation of systemic inflammatory mediators. There are many systemic manifestations of sickle cell disease during childhood and adolescence that are listed in this slide. I would be remiss if I did not mention penicillin prophylaxis as a core part of initial treatment in sickle cell disease. There was a landmark multi-center study in the 80s which described the use of penicillin in young children diagnosed with sickle cell disease and resulted in 84% reduction in invasive pneumococcal disease, which led to universal newborn screening program in the US incorporating sickle cell disease as part of the newborn screening program. So all infants diagnosed with sickle cell disease are started on penicillin prophylaxis, and it's continued until 5 years of age. These are the recommended vaccines for individuals with sickle cell disease due to their asplenic situation. The CDC and AAP recommended primary vaccine schedule. And above that, we add on the quadrivalent meningococcal vaccine, meningococcal B vaccine, and the advice of seasonal influenza and SARS-CoV-2 vaccine as well now. So moving on to the specific treatment modalities, there are disease-modifying and curative treatments. The curative treatments will be discussed at a subsequent talk, so I will not be addressing transplant during my talk. Among the approved disease-modifying treatments, blood transfusions have been the cornerstone of treatment. And along with transfusions comes iron overload, as described by a previous speaker, and iron chelation is also a core part of treatment of sickle cell disease. Other currently approved treatments include hydroxyurea, L-glutamine, pembrolizumab, and voxelotor. We talk a little bit about these approved treatments. Blood transfusion, I will not go into depth of it, just touching on basic points. So it's extremely important to remember that that antigen-matched blood should be used as far as possible, extended phenotyping to be done to avoid the development of alloimmunity in these patients. It's important to screen for blood-borne infections at least yearly, and very important to keep track of the number of transfusions and to monitor for iron burden. So transfusional hemosiderosis is a very serious complication. The effects of iron overload can affect many organs, including the heart, the liver, endocrine organs. An assessment of iron content can be done by ferritin, although in individuals with sickle cell disease, it can be very variable. So a cardiac or a liver MRI, or in places where MRI is not available, a liver biopsy would be more accurate ways to measure iron content. Iron chelators that are currently approved for use are desferoxamine, deferocyrox in its various forms, and the deferriprone. Moving on to fetal hemoglobin and its importance in the world of sickle cell disease. Fetal hemoglobin production is governed by two genes, the G gamma and A gamma on chromosome 11. And it's been well described that fetal hemoglobin levels, the higher the fetal hemoglobin levels are, as described in the populations in the Arab Indian versus the Bantu population, the severity of disease is much lower in that first group, the first haplotype versus the last. There are many genetic modifiers of the fetal hemoglobin gene that we know and have been well described in the literature. The C to T polymorphism in the locus promoter of hemoglobin of the gamma2 gene, which is a cleavage site for XMN1, is responsible for increased fetal hemoglobin levels in the Arab Indian and Senegalese haplotypes. Also well described is the BCL11A, which is a gene repressor. The ZBT-B7A, also a gene silencer, and the MYB polymorphism, which is a gene repressor. Hemoglobin F, the presence of hemoglobin F inside the cell in association with S increases the solubility of S, therefore decreasing the polymerization. Therefore, a higher hemoglobin level is equivalent to less sickling inside the cell. So the first well-described fetal hemoglobin inducer is hydroxyurea. It's still being used, and I think we have the most experience with use of this particular drug. There are very many mechanisms of action of fetal hemoglobin induction, lowering neutrophil and retic counts, decreasing adhesiveness, improving rheology of neutrophils, red cells, reducing hemolysis, and also NO release with potential local vasodilatation. There have been many trials with using hydroxyurea. The largest one, the oldest one, was a multi-center study of hydroxyurea in adults from 1992 to 2008, which showed that there was a significant decrease in frequency of pain events, acute chest crises, hospitalization, and transfusion requirement with the use of hydroxyurea at an initial dose of 15 mg per kg per day, increasing to a maximum tolerated dose at 12 weeks. Further studies in pediatrics also showed the efficacy and the safety of use in a pediatric population. Continuing on into the baby hug studies, where hydroxyurea was used in children 9 to 18 months of age, also showed safety and efficacy in this age group as well. So currently, hydroxyurea is used across the world. Sorry for the small font. On the left side is the guidelines for use with the laboratory studies before initiation, dose escalation recommendations, dose modification, and monitoring. And then recent publications also by Dr. Russell Ware, who's done a lot of work in this field, with use of the drug in Africa in helping patients there with sickle cell disease, decreasing vaso-occlusive crises, decreasing hospitalizations, and a more relaxed approach of monitoring of every 2 to 3 months versus monthly monitoring that was required on the earlier guidelines. Moving on to L-glutamine. So we're aware that NAD is an antioxidant that protects hemoglobin from oxidant damage. L-glutamine is a precursor for NAD. It's an amino acid. It reduces the oxidant stress via improvement of NAD redox status in RBCs. The pictures in the that are shown below on the left-hand side is a smear showing permanently sickle cells in the peripheral smear of room air incubated venous blood from an individual with sickle cell disease at baseline. And on the right-hand side, 12 weeks after treatment with L-glutamine, a smear from the same patient showed a significant decrease in permanently sickle cells. And this was published by Dr. Nihara, who actually did all the work, early work on L-glutamine. So the phase 3 study of L-glutamine for sickle cell anemia and sickle beta 0 patients that was done at 31 sites in the US showed that there was an improvement in time to the first pain crisis and also time to the second pain crisis in these patients, and also a decrease in severity of the intensity of the pain crises. The adverse events with L-glutamine on the trial were primarily GI related, but were shown to be easily reversible or stop or improve if the drug was held or stopped for a short period of time. The median incidence of crises was 3 events in the treatment group versus 4 in the placebo group, which was statistically significant. There was a mean cumulative hospital days were lower by 41%, and acute chest crises were lower as well. The median time to first crisis was 87 days in the treatment group versus 54 days in the placebo group. So L-glutamine is currently approved for use. It's an amino acid. It's approved in pediatrics and adult patients 5 years of age and older. The dosage forms as an oral powder, which comes as a 5 gram per packet. And the dose, as you can see, is weight-based, as is being described in the slide. Moving on to crizanlizumab, which is a P-selectin inhibitor. Selectin, as was described earlier, is an adhesion molecule on activated endothelial cells and platelets, and it's a key molecule in initiation of leukocyte rolling on vessel wall. And it plays a very important role in the pathophysiology of sickle cell disease. So when you have activation or upregulation of P-selectin, the cells are more sticky, you have more adhesiveness onto the endothelium, neutrophils, platelets, and ultimately your red cells all adhere and cause vaso-occlusion. So CELG1, or crizanlizumab, as it ultimately got named, was a first-in-class humanized anti-P-selectin antibody. And this study, the SUSTAIN clinical trial for crizanlizumab was a multi-center randomized placebo-controlled study, which had a placebo arm, a low dose, and a high dose drug arm. It was studied in patients 16 years to 65 years. And the important things that were shown on the study was that there was a significant improvement in median time to first pain crisis in individuals on the drug versus individuals on placebo. In terms of toxicity, the primary SAEs reported on the study were arthralgia and pruritus. There wasn't any apparent increase in infections during the study. There were 5 deaths, 2 in the 5 milligram per kilogram group, 1 in the 2.5, and 2 in the placebo group. So it was not a significant difference across the study groups, and none of the deaths were deemed related to study drug. The conclusions from that study was the treatment with high-dose CELG1 resulted in clinically meaningful reduction in the frequency of VOCs in patients with sickle cell disease. There was a 41% reduction in frequency of VOC with the high dose XLD1, and median times to first and second crises were extended 2 to 3-fold compared to patients who received placebo. The incidence of adverse events was low. So at this point in time, crizanlizumab is approved for use in individuals 16 years of age and above who have sickle cell disease. The dose is as described, and it's administered every 4 weeks as the maintenance dose. It can cause some platelet clumping. So when you have patients who are on crizanlizumab or Adakveo, as it's called, if you need to do an accurate CBC and platelet counts, you need to collect the blood in citrated tubes. Moving on to other modalities. So hemoglobins with altered affinity, oxygen affinity, have also been studied for sickle cell disease. So P50 describes the affinity of a given hemoglobin for oxygen, and it is the PO2 at which hemoglobin is 50% saturated with oxygen. So as your P50 decreases, your oxygen affinity increases. And so which means if your hemoglobin remains oxygenated, there is less chance that a hemoglobin S molecule staying oxygenated is going to sickle. So your goal would be to keep your sickle molecule as oxygenated as possible. So voxelotor is a novel small molecule that reversibly binds to hemoglobin, specifically the alpha chain of the hemoglobin molecule. It stabilizes hemoglobin in its oxygenated state. So as you look at the oxyhemoglobin curves here, if you imagine your hemoglobin S curve being somewhere there with the P50 a little further out, studies have shown that in the presence of voxelotor, your P50 actually shifts to the left, more towards a normal hemoglobin A. And so it inhibits hemoglobin S polymerization as the molecule stays oxygenated. It reduces RBC sickling, improves viscosity, and improves red cell deformability in vitro. It was also shown to extend RBC half-life, reduce anemia and hemolysis in patient studies. There was a phase 3 HOPE trial performed on this drug. It was a randomized placebo-controlled international multi-center trial in individuals 12 to 65 years of age. And the primary endpoint was to look at participants who had a hemoglobin response defined as more than 1 gram per deciliter increase in hemoglobin level from baseline to week 24. And this is the initial
Geetha,
result.
I'm sorry to interrupt you, but you have 5 minutes. Thank you.
All right. So this was the early results from the HOPE trial showing that the 59% had a hemoglobin response. The response was sustained until 24 weeks of age. Until 24 weeks of the study. And on the long-term follow-up study, it showed that the results were sustained. Hemoglobin response was sustained at 72 weeks. Also showed a slight decrease in the number of vaso-occlusive events, not statistically significant, but the curves showed that there was some change there. So voxelotor is currently approved for use in patients with sickle cell disease. There is a weight-based dosing that is described there. So under many ongoing trials, I just picked out a few that have some phase 3 trials going on. So there are disease-modifying studies or disease-modifying agents. Inclacumab is a selectin inhibitor. There are some pyruvate kinase activators, and crovalimab, which is an anti-complement C5 monoclonal antibody. There are also curative interventions, transplant, which will be addressed later, gene therapy, which includes a gene replacement or a gene addition, and gene editing as well. So we'll touch on a few of these. So inclacumab is a recombinant IgG4 monoclonal antibody, which competitively inhibits P-selectin, as a longer dosing interval as compared to crizanlizumab. That one was about 4 weeks, and this is about 3 months, 90 days. So there are some clinical trials ongoing with inclacumab, a phase 3 randomized double-blind study, looking at individuals more than 12 years of age, looking at the study drug versus placebo administered every 12 weeks, and the primary outcome measure is the number of VOCs during the 48-week treatment period. There is also a single-dose study looking at primary outcome being readmission for a VOC within 90 days of randomization to study drug versus placebo. Moving on to pyruvate kinase activators. So this is the glycolytic pathway, and at the terminal end of this pathway, there is pyruvate kinase here, which is responsible for ATP generation from this pathway. And it has been shown in individuals with both sickle cell disease and thalassemia that red cells have a relative PK deficiency or maybe a PK instability, and therefore the use of these pyruvate kinase activators in these conditions. So mitapivat is one of those pyruvate kinase activators that has gone through phase 1, phase 2, and is currently in a phase 2 to 3 double-blind randomized placebo-controlled study. Itavupivat is also in some phase 2 and phase studies, hibiscus and gladiolus, which is ongoing in patients 12 and above, looking at itavupivat, looking at decrease in need for transfusions. Gene therapy, as I mentioned, there's gene insertion or gene editing. Gene insertion is looking at primarily insertion of a normal, if you will, hemoglobin or beta globin gene into stem cells derived from a patient with sickle cell disease, and then gene modified and infused back into the patient after single agent busulfan myeloablative conditioning. Gene editing involves silencing of the BCL11A gene using CRISPR. It's a modality that's being studied at this point. So the stem cells again are taken out of the patient. The BCL11A, this gene editing that happens to those stem cells, the cells are then reinfused into the patient again after single dose or a single agent busulfan has been administered, and then you wait for engraftment and monitor for response. So there's a lentiglobin studies for sickle cell disease that were done in the US. There were 3 groups, A, B, and C. The largest group was Group C with 35 patients. Group A is important because there were some important SAEs that I'll talk about. 7 subjects received lovo-cel, which is the name of the product. There was suboptimal expression of the modified hemoglobin molecule that led to a refined manufacturing process that was used in the subsequent groups. The cells were collected after plerixafor mobilization and apheresis, infused into the patients after a single agent busulfan was administered, and this shows the biologic clinical efficacy of lentiglobin in sickle cell disease, showing significant. There was some improvement in hemoglobin levels, mostly from the modified hemoglobin. And if you look at this figure here in red, is the modified hemoglobin molecule that is produced from the inserted gene, and more than 50% of total hemoglobin was made up by that modified hemoglobin, which also has an anti-sickling property. Hemoglobin levels, as you can see, were more than 10 to 11, close to 11 grams per deciliter on most patients. And this is an improvement from baseline. Now, if you look at the response or efficacy of the treatment, if you look at this particular line as day of infusion of the product, 24 months prior to administration, each little red dot is a VOC on each of these individual patients. So this is pre-infusion of the lentiglobin product, and this is post-infusion of the lentiglobin product. So the top graph talks about severe vaso-occlusive crises. So there were many before and significantly decreased number after. And this was all VOCs before, significantly decreased after lentiglobin infusion. So definitely clinical efficacy was proven. There were 2 very important SAEs that were reported in Group A patients. The patient 2 in Group A was initially diagnosed with MDS 3 years after lovo-cel infusion, which progressed on to AML, and the patient ultimately passed away. None of the lentiviral vector was found integrated in the CD34 blast population of the patient. Monosomy 7 was found, and ultimately it was determined that the MDS and AML was unlikely related to lovo-cel and was attributed to the use of busulfan as a conditioning regimen. And patient 1 in Group A was also diagnosed with AML at 5.5 years after the lovo-cel infusion, and that patient too unfortunately passed away as well. There was lentiviral insertion identified in the blast cells. It was inserted in the VAMP4 gene with no known role in the development of AML or oncogenesis. There were several other known AML driver mutations identified in the blast cells in genetic testing, including monosomy 7. And AML was ultimately determined unlikely to be due to the lentiviral vector insertion. And that was based on the data they observed from insertion site location, low transgene expression, and the lack of effect on surrounding genes. So the results from group C showed that there was good sustained production of the modified hemoglobin molecule with near complete resolution of VOEs. There is no malignancies have been reported so far, and ongoing long-term follow-up is continuing. BCL11A.
Dr. Geetha, our time is over, I'm afraid. I'm sorry to interrupt you. Can we conclude? Thank you.
Yes, yeah, I will just go to my last. I just have 2 more slides. Talking about the study in sickle cell patients with 1-to-1. It's just showing the data here of improved hemoglobin production in all 31 patients were VOC free after exa-cel infusion at 2 to 32 months post infusion. No patients had any SAEs. There was 1 mortality due to a SARS-CoV-2 infection, and there are some ongoing trials in this field as well. So I appreciate the invitation again. Sorry I went over time a little bit, but thank you again.